morning, friends. Today's lecture is on myeloma in 2022, what has changed. And our guest speaker is Dr. Farooq Wandru from Birmingham, UK. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS, managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Rajesh Sharma and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Pritesh Junagade, hematologist from Nashik, our guest speaker, Dr. Farooq Wandru from UK, all our discussants who are themselves eminent hematologists, medical oncologists, you participants for sparing your Sunday morning, if you are from India and any other part of the world, maybe afternoon, maybe evening, and maybe night. Understand that we have registrations from almost 25 plus countries today, and that speaks volumes about the speaker and the subject and its importance. We have next Sunday, 1st May, 11:30 a.m., a webinar on Willebrand disease, both on diagnosis and management. Professor Jasmina Ahluwalia from PGI Chandigarh will cover the diagnosis, and I'll be speaking on the management. Our discussants today include a large number of very important persons. To introduce them, we have Dr. Abha Dubey from Shalby Hospitals, Ahmedabad, Dr. Afaq Ahmed Khan from SKIMS, Srinagar, JNK, Dr. Aishwarya Raj from GCRI, Ahmedabad, Dr. Ankit Jitani from Apollo, Ahmedabad, Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad, Dr. Asif Iqbal from Dr. Bhubaneswar Barua Cancer Institute, Guwahati, Assam, Dr. Bharit Parikh from Vedanta, Ahmedabad, Dr. Eva Bhagat from Kyo Center for Complete Care, Ahmedabad, Dr. Jay Chandran from Cancer Institute, Adyar, Chennai, Dr. P.P. Abdul Shahid from KIMS Cancer Center, Trivandrum, Dr. Parathan Karunakaran from Cancer Institute, Adyar, Chennai, Dr. Ragesh Radhakrishnan Nair from Calicut, Dr. Reshma Roshan from SKIMS, Srinagar, JNK, Dr. Rupam Deka from Bhubaneswar Barua Cancer Institute, Guwahati, Dr. Samoon Jilani from SKIMS, Srinagar, JNK, Dr. Shinto Francis Takudan from Kozhikode, Kerala. Our guest of honor today is Dr. Pritesh Junagade from Nashik. He is MD Medicine, MRCP UK, MRC Path UK, CCST UK. And we are privileged to have his presence today to inaugurate our today's webinar. Everyone in India knows him. However, to complete the formalities, he has his wonderful and a very prestigious center in the name of Lotus Institute of Hematology and Oncology in Nashik, of which he is the director, and where he also performs stem cell transplantation, of which he has done almost 500 allogenic and autologous transplants already. Earlier, he was honorary hemato-oncologist at Royal Marsden Hospital, London, UK, and bone marrow transplant physician at King's College Hospital, London. He had been the specialist registrar in Department of Hematology, King's College, Eastbourne District General Hospital, Eastbourne, UK, Ealing Hospital, London, UK, Royal Free Hospital, London, UK, St. Mary's Hospital, London, UK. He did his MD Medicine from University of Mumbai in 2001 and obtained first rank at the university and received Dr. C.D. Patel Gold Medal. Subsequently, he did MRCP, King's College, London. He is recipient of Distinction in Pathology in 1995. He is recipient of Best Paper Award at the Annual Conference of Physicians of India, Jaipur, 1999. Dr. Pritesh, we are really privileged by your presence today. Thank you very much for sparing your important moments to inaugurate this webinar. And now over to you.
Thank you, sir, for the kind introduction. and I'm really privileged to be a part of this webinar. And I'm already inspired from you by arranging, all these webinars throughout the year and in the pandemic. We have learned so much from you. Uh, uh, I think hematology in this country has really progressed in last decade or so, since the time I came from UK. And I think most of the credit goes to my professor, Dr. M.B. Agarwal, who was my guide at Lokmanya Tilak Medicine Hospital. I think many junior hematologists have been attending these webinars attended by you. And I think the only thing I can tell from my side is that if you are passionate about this field or any field, I think you can succeed. Even in tier 2 cities in India, I think there is great need of trained hematologists in such tier 2 and tier 3 cities. And I'm sure many of those listening here or training in hematology or oncology would be glad to serve the people in these cities, because we need to make sure of their financial status, how they can afford the world-class treatments locally as well. So really, it's a privilege to be a part of this webinar, and I'm thankful to the entire team of this webinar. Thank you so much.
Thank you so much, Pritesh, for your kind words, sparing your important moments and joining us. My memories go back to when you were working with us, and then also at number of occasions when we visited Nashik, your hospitality, your father's hospitality, and the wonderful moment that we have had in the various meetings you have organized in Nashik for the field of hematology. Thank you so much. The most important statement that you made, that you're most welcome. The most important statement you made is it's an art to learn how to treat patients in India within their monetary capacity. It's something which the Western world cannot teach us. We have to learn. It's extremely important when the patient is paying from his pocket, what to do, what not to do, how to manage him with his restricted resources. I think that is one very, very important message you have sent, and the students and the postgraduates and the residents and even the junior colleagues will probably keep this in mind while handling delicately their patients in this country. Oncology is an expensive branch, and it's becoming more and more and more expensive. And this is really something which you learn during your practice. Thank you so much. And we are going to move on. So we now have our Sunday quiz. As usual, you will be guessing the answer and forwarding the reply to mbagarwal1@gmail.com. The winner will be fastest finger first, once again, as usual. So this is related to coagulation, and as you know that factor 8, factor 9, deficiency, von Willebrand factor, and factor 13 are the 4 commonest disorders that we see in India and probably worldwide. Factor 13, of course, varies with its geographical distribution. Today, we are talking about von Willebrand disease and its subtypes, which you know that there is quantitative deficiency, partial in type 1 and virtual complete in type 3. And then there is a dysfunction of the molecule giving you the type 2. And there are 4 subtypes, A, B, N, and M, and I'm not going to go into the details of that. Let's come to the quiz. So this quiz is related to a patient of von Willebrand disease. This patient has undergone tests for von Willebrand factor antigen, von Willebrand factor platelet binding activity, the test what is called RECOG, and the factor 8 coagulant assay. The results showed that patient has type 1 disease. He then undergoes vasopressin or DDAVP or desmopressin challenge. Now I will show you a flow chart in which there is one blank, and you have to guess what should be there in that blank, and whatever should be there in that blank, you have to forward that answer. Okay? So von Willebrand disease, type 1 desmopressin challenge, and based on the result, there is a flow chart in which there is something blank. What that blank stands for, email that to mbagarwal1@gmail.com. The winner will be fastest finger first. And after, we have the lecture by Dr. Farooq Wandru. And before we go to the question answer session, in that gap, we are going to give rest to Dr. Farooq for 2 minutes, and I will give you the winner's name. Also, the names of all those who gave the correct answers in the order in which they gave that answer. This is the flow chart. So this patient has undergone antigen assay, platelet binding activity, and factor VIII coagulant assay. The results showed that this patient has got type 1 disease. He undergoes DDAVP challenge. If there is no premature clearance of von Willebrand factor, we call it type 1. If there is a premature clearance, then what do you call it? Is the question to you. So type 1 von Willebrand disease undergoes desmopressin challenge. If there is no premature clearance of von Willebrand factor, then that is standard usual type 1. And if there is a premature clearance of von Willebrand factor, then what is your diagnosis? So forward your answer to MB, I'm sorry for the mistake here, Agarwal, AGARWAL1@gmail.com. Okay, MB Agarwal1@gmail.com. Okay. The next part of our this morning activity is to have a case study for the week. Now, in this case, you don't have to guess anything. I'm going to give you everything. It's a very interesting and a very unusual case, which you will diagnose only if you know about this entity and if you keep investigating for this entity. Parveen, 17-year-old girl from Ratnagiri, saw a local hospital at the age of 5 years for anemia. She was treated with response. We don't know. She was treated with hematinics, and we don't know the response as there was no follow-up. Subsequently, she was repeatedly seen at that local hospital for recurrent or refractory anemia. And these visits were at the age of 9 years, 13 years, and 15 years. Records showed that her hemoglobin was usually around 4 to 6 grams, and the MCV and MCH were very low. Based on that, she received hematinics for a variable period of time each time. And the hemoglobin increased up to 6 G, not more than that. The stool local blood was tested off and on, it was negative. She was investigated for celiac disease with TTG, IgA, and IgA endomysial antibody. The results were negative. She was investigated for thalassemia and hemoglobinopathies with HPLC. The result was negative. So we have a young girl who has been anemic for 12 years with hemoglobin 4 to 6, MCV, MCH low, not responding adequately to iron therapy. There's no bleeding, there's no celiac disease, there's no thalassemia, there's no hemoglobinopathy. She came to us last year. She's a product of consanguineous marriage, and she's got 2 siblings who are healthy. Her dietary history was good. There was no pica, no GI disturbances, no bleeding from GI tract, and no menorrhagia, and she's never received blood transfusion. She never had any significant infections, no Ayurvedic medicines. Though she has been anemic all her life, she was very well grown. Except for Pella, there were no physical signs, there was no polyonychia. There were no findings to suggest hemolysis, organomegaly, nothing to suggest inherited bone marrow failure syndromes, and there was no skeletal abnormalities. Both parents enjoyed an excellent hemoglobin, father 15, mother 12. That's her own lab data last year. Hemoglobin 5.9, MCV, MCH very low, white cell platelet okay, retic okay, ESR okay, serum iron low, TIBC high, transferrin saturation low. So classical so-called iron deficiency anemia, ferritin 282, normal or on the higher side. This is her peripheral smear, microcytic hypochromic. The lab data that raised a question about the diagnosis was ferritin 282 in the absence of any infection, inflammation, or anything that can cause acute phase reaction. So a diagnostic test was ordered. Many of you might have guessed what this diagnostic test could have been. And this was TMPRSS6 gene mutation study by NGS. For a disease called IRIDA. IRIDA stands for iron refractory iron deficiency anemia. And that's what our patient was. She was on iron study, iron deficient, but she didn't respond to iron. So she was iron refractory iron deficiency anemia, which is a genetic entity where this particular gene is mutated. So what is IRIDA? Iron refractory iron deficiency anemia is an autosomal recessive disease, commonly present in children, but can first time present in adolescent or even adults with classical hypochromic microcytic anemia with lab features of iron deficiency, like low serum iron, raised total iron binding capacity, and low transferrin saturation. If you stop here, you will probably think this is classical iron deficiency only. However, ferritin will be invariably normal or even high, and patient will not respond to oral iron therapy. And these two are the important statement to suspect this IRIDA. IRIDA is due to mutation in the gene TMPRSS6. What this mutation does, it leads to elevated levels of hepcidin. Hepcidin blocks the iron absorption from the intestine and its release from the macrophages. As a result of which, no iron can reach the bone marrow, and therefore patient will not respond to the iron given by mouth. If you inject iron intravenously, however, because it will bypass the hepcidin, there is response, although this response is usually partial. So how to suspect, diagnose, and treat IRIDA? Microcytic anemia from early childhood, if you have records. Autosomal recessive, so siblings may be involved. Consanguinity history may be present. Disproportionately normal or high ferritin is the first lab clue. If you have an access to hepcidin estimation, it will be high. And if you have done hepcidin, you can look at the ratio of transferrin saturation, which is low, and hepcidin, which is high. And therefore, this ratio is extremely low, and it's in the diagnostic range. And then you should order for this rare gene by NGS, the TMPRSS6, and sequencing of this gene will give you the final diagnosis. And the treatment will be to give intermittent IV iron therapy, and there is some help by giving vitamin C. So your investigations of iron deficiency versus IRIDA, the difference will be here. The ferritin will be normal or high, and hepcidin, if you do it, it will be high. Rest everything is same. And this is a publication showing you the transferrin saturation to hepcidin ratio, discriminating TMPRSS6 related IRIDA versus various causes of iron deficiency anemia. It's rare, but it is believed that it is underdiagnosed worldwide, and therefore it is rare. It has no geographical distribution. Individuals of all racial and ethnic groups are affected. Hepcidin and ferroportin are the two critical proteins that regulate iron homeostasis. Excess of hepcidin through ferroportin, which is the only iron export protein in the body, blocks the iron absorption from the gut. That's a 25 amino acid structure, hepcidin, which is produced from liver and which has the capacity of acting as an antimicrobial agent, and which is the master hormone for iron hemostasis. So hepcidin blocks iron absorption, blocks its release from macrophages. TMPRSS6, when it is mutated, there is excess of hepcidin, blocking the iron absorption through ferroportin and blocking the release of iron from the macrophages through ferroportin. The structure of TMPRSS6 gene is extremely complex, and therefore there are a large number of mutations leading to this entity. And when you give parenteral iron therapy, this is a case published in the journal. Hemoglobin can go up from 4 grams right up to normal in a case of IRIDA. There is a publication showing that IRIDA has something to do with autoimmune polyendocrine syndromes. The exact relationship between these two is not clear, but patients of autoimmune polyendocrine syndromes have higher incidence of IRIDA, and they should be looked at. And that's a publication, British Journal of Hematology. Very high frequency of TMPRSS gene variations in iron deficiency anemia of patients having polyendocrine autoimmune syndrome. Is this more than a causal association? Published by the Italian workers. So that was the case study of the week. And now we come to the main part of the webinar today, and that is our guest lecture by Dr. Farooq Wandru from Birmingham, UK. It's my proud privilege to introduce him to all of you. He's consultant hematologist with deep interest in the subject of myeloma at Sandwell and West Birmingham Hospitals NHS Trust, an honorary senior lecturer at the University of Birmingham, UK. He is from India. He graduated from the Medical College Srinagar, Kashmir, way back in 1987, and obtained MD Medicine from University of Jammu in 1992. He was a consultant hematology at SKIMS, and we have 3 of the discussants present today to listen to him, between 1995 to 96 before he moved to UK. He received training in hematology in London and the West Midlands Deanery from 1998 to 2004 and obtained his MRC path from Royal College of Pathologists, London in 2004. His principal areas of interest include myeloma, chronic lymphocytic leukemia, and T-cell lymphomas. He was one of the principal investigators for UK Myeloma 11 clinical trial, which is the largest myeloma trial ever conducted, and a member of the UK NCRI T-cell lymphoma group, member of the UK West Midlands Research Consortium and British Society of Hematology. He is interim president of UK British Kashmiri Medical Association from 2019 till date, and he's member of the Global Kashmiri Hematology Faculty Group. He's a senior academy tutor for medical school at University of Birmingham and MRCP, PACES, host examiner, and RCPath medical examiner. He's going to lecture today on Myeloma in 2022, what has changed. I'll stop here and request him to deliver his talk. So over to Dr. Farooq Wandru.
Let me just try to share my slides first.
Sure.
Can you see the slides?
Yes.
I can just see whether they're moving, yeah?
They're moving.
Okay. So thank you, Dr. Agarwal. Good morning and good afternoon, good evening, wherever you are listening to this morning. It's 7 o'clock, 7:20 here in the UK. Thank you, Dr. Agarwal, for your kind introduction. And it's a great pleasure to be with the faculty across India and in the other countries. I can see a distinguished panel of faculty members. It's a great pleasure to be part of it, to be interacting with you guys. And I'm also pleased to see some of the colleagues from Srinagar in the panel. So we start, we'll look at the, how we manage myeloma in 2022 and what has changed. So these are my disclosures. So we'll look at the change in the diagnostics, the Frontline and changes in the treatment of relapse, and also some of the newer treatments. Now, what has changed recently is that we now have a better understanding of the disease biology, including both the myeloma cell, just antigenic structure, as well as the tumor microenvironment. There are some changes in the diagnostic criteria proposed by MWG, and also there's some proposals for changing in the imaging modalities for diagnosis. We now have availability of monoclonal antibodies for both upfront and relapse disease. Maintenance treatment is now a standard of care. There are now 2 CAR T-cell products approved by FDA and imminently to be approved also in European Union and UK. And we also have a number of anti-BCMA therapies now approved. There are a number of bispecific antibodies or T-cell engagers lots of newer therapies are available, which are showing great promise. So much of the myeloma is now a livable disease or as a chronic disease. However, the challenges remain that it is an incurable disease. The patients have to live with the burden of the disease and with the cumulative side effects, because a number of patients are on multiple therapies and maybe on even continuous treatments. Therefore, it's very important when we treat these patients that we have to balance the risks of treatment versus the quality of life. The challenge remains of how we manage the high-risk disease. And there's also obviously a financial burden on the healthcare with the availability of expensive drugs. And many of these drugs are still not off patent, although this might change very soon. So this is how myeloma, if you compare it with other cancers, this is an Italian study which shows that myeloma is somewhere here with a 5-year survival, 50% 5-year survival rate. And if you compare that with the melanoma and prostate tests at the top here, and the worst is for the lung and the pancreas, and also kind of leukemia also stays somewhere here in the middle. And we have made progress. The survival in myeloma has improved, particularly with the introduction of novel agents from early 2000. And the survival has been seen both in the elderly as well as the younger myeloma patients, with about median survival around 7 years for younger patients. This is the snapshot from Cancer Research UK, which looks at the 1, 5, and 10-year survival of myeloma patients overall, both elderly as well as younger patients. And as we see, majority of the patients will live 1 year, but about the 5-year survival is around 50%. But there is about a third of patients who actually can survive beyond 10 years. And this continues to improve with the evidence with the introduction of novel agents. The problem with the myeloma, however, is in the delay in the diagnosis. So this was a study done by UK Myeloma Forum, which is a Myeloma UK charity, looking at the number of cancers diagnosed in the primary care and the number of times these patients had to make visits to the GP. As you can see, myeloma is on this side, and on an average, the myeloma patients has to visit the primary care physician at least 3 times, as compared to look at the breast and the testes, which are diagnosed just in one go. And another study by the same group was published only last week, which looked at the impact of delayed diagnosis on the quality of life and the development of complications. As you can see, about 25% of myeloma patients take a year for diagnosis, and some see the GP at least 3 or 4 times. And about 1/3 of the patients are actually diagnosed because they present with complication to the accident emergency. And the delayed diagnosis clearly had an impact on the quality of life, and also on the number of complications. You can see the delayed diagnosis, these patients develop more bone fractures, spinal cord compression, and infections. So there's a need for educating our primary care physicians and internists in referring the myeloma patients early, in picking up the myeloma patients early. We can understand, because the reason for delaying diagnosis is the non-specific presentation of myeloma, which may be just symptoms like fatigue or bone pain or normocytic anemia, which primary care physicians do not think first time, but we need to educate them if you want to prevent the complications and treat these patients early. Now, it's not well known that myeloma initiates from the post-germinal central B cell, and it goes through the stages of MGUS to smoldering myeloma to ultimately leads to the plasma cell leukemia. And during that time, the primary genetic events which perhaps initiate the clonal advantage or the IgH translocations and the hypertriploidy, and there are then secondary events which includes the copy number abnormalities and the acquired mutations. Now, it has also been shown that nearly all multiple myeloma patients start from MGUS, or the MGUS precedes multiple myeloma. This has been shown in the 2 American studies by retrospective screening. And therefore, there's an emphasis on early detection. And this study called ISTOP-M was presented at ASH this year, which was done in Iceland. And they actually did a prospective screening of a large number of patients, about 145,000, and out of which about 75,000, 5,000 people were actually screened for MGUS and myeloma, and they actually found that the prevalence of smoldering myeloma was higher than we expect, about 0.5% in healthy people, and whereas the incidence of MGUS was kind of 5%, which is similar to what has been seen by the Mayo group. But what they did is for these MGUS patients, which were mostly low-risk patients, they actually randomized them into 3 arms, arm 1, 2, and 3. And arm 1 and 2 were followed up as you would normally follow them. Arm 1 was, there was no further follow-up, whereas the arm 2 was the guideline driven. But in the arm 3, they actually did intensive monitoring with serum free light and assay and repeated bone marrow examinations, which kind of seems a bit too much for a healthy population. But what they found is that in the intensive arm, they actually picked up more smoldering myelomas over the time. So that kind of tells us that there is more myeloma around than we think. But is it worth screening a healthy population, and the psychological impact of telling somebody you've got MGUS or smoldering myeloma when they're very healthy, and what will be this impact on whether or not these patients would then be, how they be monitored, how they be treated? I think that's something to be thought about, but this study is still preliminary, and a lot of things will come out of it in terms of there may be a subgroup of in the population, like elderly or from a particular ethnic group, which people might consider screening in other places. There's also an emphasis on treating smoldering myeloma patients early, and there are a number of risk stratifications have been proposed by the IMWG, which looks at the free light chain ratios, the M protein, and the percentage of bone marrow plasma cells, as well as the FISH abnormality. And obviously, if you score high, then your chance of developing myeloma within 2 years is nearly 80%. Therefore, there are a number of clinical trials ongoing, especially from the Spanish group, which are looking at using upfront-like treatment, what we use for upfront myeloma patients, which includes lenalidomide-based or carfilzomib-based, or even daratumumab-based treatment nowadays. And that has shown that if you treat high-risk myeloma patients early, then you can improve the overall survival, as well as prolong the time to progression, or may not actually, some of these patients may not even progress. And whether you can actually cure them early or prevent the development of myeloma. So that's kind of debatable. It is still in the context of clinical trials, but it is something which is evolving all the time. So what are the changes in the diagnostics? Now, previously we used to say whether there's any value of doing a FISH, because there was nothing to offer to these high-risk patients. But now this is a recommendation that FISH for genetic abnormalities should be done, because there is evidence that combination of proteasome inhibitor or monoclonal antibodies may be the best induction regime for these poor risk patients, although this is still being tested in the context of clinical trials. The high-risk cytogenetics listed here, as these have now been validated in a number of clinical trials, that about a third of the patients do harbor these high-risk genetics, which carries a poor prognosis. And some of these patients may have either a single hit or a double hit or even a triple hit, or in mutations or these chromosome abnormalities, which confers poorer prognosis. And of course, there are then other prognostic factors to be kept in mind, like extramedullary disease or plasma cell leukemia, high LDH, and also patient-related factors like age, performance status, renal failure, and frailty. Now, we don't need the CRAB criteria now to treat myeloma. So there are these IMWG recommended SILM criteria, which, if present in the absence of CRAB criteria, are enough for both diagnosis as well as treatment of myeloma. So, and the prognostics or the staging system has now been revised, what's called revised ISS, because it now includes also the genetic test. And so if you, for example, ISS stage 3, which would be normally a beta to M of more than 5.5, but if you incorporate high-risk genetics by FISH, or LDH at the upper limit of normal, and then that would be an RISS stage 3, which has an inferior 5-year overall survival rate. So it just tells you here that if you don't have FISH or genetic tests available, the LDH is sufficient to kind of be an alternative for that. Now, it's not just one genetic abnormality, but the myeloma, MRC myeloma UK trials have shown that the number of adverse risk, number of adverse genetic factors also confers a poorer prognosis. So there's a subgroup of patients who actually do badly. There's also now emphasis on gene expression analysis and DNA sequencing, which might further refine the prognostic group of RSS by incorporating these mutations. So it's now been seen in the myeloma trials that if you have a double his mutation or a biallelic mutation, that confers even a poorer prognosis. Now, it may be emphasized that the myeloma 11 clinical trial actually showed that in the elderly population, it's not actually the tumor genetics which drives the poor outcome. It's actually the WHO performance status and the ISS staging, which is more important in terms of determining the prognosis, because of this ISS stage and the poor performance, elderly patients do not get adequate treatment, and that's one of the reasons that they do poorly. So, as far as the imaging is concerned, there is now clear guidance from the IMWG and various other professional bodies, including NICE and BSH from the UK, and that skeletal survey is not the recommended modality of diagnosis as far as imaging is concerned, but they recommend cross-sectional imaging with either whole body low dose CT or PET or whole body MRI. The reason for that is because the skeletal survey is a very insensitive method of picking up early lesions. It needs at least 70% of the cortical bone loss before the skeletal survey will pick up the lesions, whereas the MRI, CT, and the PET CT are much more sensitive, and they will also be helpful in, especially the PET, in monitoring the disease, and even it is being used for the minimal residual disease as one of the modalities. So what has changed as far as the upfront treatment is concerned? Let me just introduce this case, which was presented only a few weeks ago. A 68-year-old female presented with weight loss, severe anemia, and high white cell count, which is mainly circulating plasma cells, moderate renal impairment, high beta-2M, and high LDH. And she had cord compression with a D12 compression. It's clearly a high-risk disease, even without calculating the ISS because of circulating plasma cells. Let me just remind you that the IMWG have recently revised the definition of plasma cell leukemia, in that if you have more than 5% plasma cells in the peripheral blood, that is sufficient to diagnose plasma cell leukemia, as against previous 20%. This has been validated in two retrospective analysis, which found that there was no difference between people who had 5% plasma cells or 20% plasma cells in terms of their outcomes. So therefore, 5% is a new definition of plasma cell leukemia, and it's also been shown that plasma cell leukemias have got much increased incidence of the translocations as well as the mutations as compared to the multiple myeloma, making it a very high-risk disease. So looking at the upfront treatments, what is available recently, in addition to your usual approach to inhibitors, immunomodulatory agents, we now a number of monoclonal antibodies, the BCMA-specific agents like belantamab, and two CAR T-cell products, and a number of smaller molecules are now available. So this is the snapshot of the milestones in the multiple myeloma evolution, and you can see that some of us who have worked in 90s, we used to have only combination of alkylating agents and doxorubicin followed by stem cell transplant. But it's all changed since the year 2000. The number of drugs have come into the market, which includes the IMiDs, the proteasome inhibitors, recently monoclonal antibodies, and now recently in this year and last year, we have the CAR T-cell products and these small molecules, which are now available for use. Now in NICE, in UK, the NICE guidance for upfront management of transplant eligible patients now incorporates daratumumab in combination with the VTD, and followed by autologous transplant, which is standard of care, and lenalidomide maintenance. We also have the RADAR clinical trial available for upfront treatment, which I can talk about later. So what has recently changed is that there were 4 major trials which have looked at the use of daratumumab in the upfront setting, the Griffin, the Cassiopeia, Master and Optimum trial. These 2 have looked mostly at the high-risk disease. The Cassiopeia trial was compared daratumumab VTD to the standard VTD, which is the standard we use in Europe. And this was followed by autologous transplant and consolidation cycles. And then there was a final randomization between daratumumab monotherapy and observation. So there's a little bit of fallacy in this trial because they used the observation as one of the arms, whereas it should have been actually lenalidomide, which is the standard of care. But they found that DVTD was superior across all subgroups, including high-risk cytogenetics and ISS stage. And there was also an increase in the MRD negativity significantly in favor of DVTD arm, which was maintained after the consolidation. And also, when they looked at the maintenance, at 2 years presented ASH this year, the MRD negativity persisted, although between 1 and 2 years, probably this was not, it was questionable. So the question of daratumumab maintenance remains to be evaluated. There's obviously a PFS advantage, which is not reached yet in favor of DVTD arm, but overall survival is obviously too early to determine. When they did a subgroup analysis at 1 year on the MRD status, and it clearly shows that those patients, irrespective of what induction treatment they received, the MRD negativity had an impact on the PFS, suggesting that deeper responses are important. So NICE has now approved Dara VTD as an upfront treatment for transplant eligible patients in the UK. What about VRD? I mean, because the Americans use VRD as their upfront treatment, so they used the combined daratumumab with VRD and compared it with the VRD exactly in the same way as in the Cassiopeia trial. But here they used maintenance treatment daratumumab Revlimid and compared with the standard of care, that is Revlimid. And what they found similarly that the depth of response and the MRD negativity improved in the DVRD arm, both after the end of consolidation as well as after maintenance. And an updated presented at the ASH this year at 24 months continue to show improvement in this CR rate in the DVTD arm of over 82%, and again an improvement continues to be in the depth of response, so the MRD negativity, but the PFS and the overall survival obviously is too early to determine. So therefore, daratumumab-based combinations have become this standard of care in the upfront setting. What do we do for the high-risk myelomas? There's no clinical consensus on this, but the current thinking is that we must aim for the intense induction, consolidation, and the continuous maintenance. Now, this is the data from Myeloma 11, which show that the high-risk patients obviously did poorly as compared to the standard risk. This is one of my patients with 1Q abnormality who was refractory to the IMiD and proteasome inhibitor and DTPase, had a partial response, which is followed by autologous transplant, but relapsed very quickly, as you would expect in the high risk in this high risk group. So there are 2 trials which were presented at ASH this year. One was the Optimum, which is a UK study, and they at a subgroup of high-risk patients whom they treated intensively with a combination treatment of daratumumab with cyclophosphamide, Velcade, and Revlimid as a quadruple induction, which was followed by an augmented autologous transplant, bortezomib augmented autologous transplant, and 2 consolidation phases of Dara VRD of 6 cycles, and then the dexamethasone was omitted in the second consolidation for another 12 cycles, and this was followed by continuous maintenance of Dara Revlimid until progressive disease. So very intense induction, consolidation, and maintenance with a view to continuously, continue the treatment until progression. And they found that, the CR rate as well as the MRD negative rate improved continuously with the continuous treatment in this trial. But there was a similar study, what's called a master study, which used carfilzomib-based induction with daratumumab, again a 4-drug combination. The difference here was, however, they used an MRD-based approach for the treatment. That means if patients became MRD negative after autologous transplant, they took them off for the treatment and just observed them. Whereas if they remain MRD positive, then they continue with the further consolidation cycles. And the ones who remained MRD positive, they continued with consolidation cycles, followed by Leonard maintenance for MRD positive patients. And again, they showed, although this was a slightly toxic regimen because of the carfilzomib-based regimen is associated with more hematological as well as non-hematological toxicity. But what they found is that in this trial, that patients who had more than 2 high-risk genetic abnormalities, in so-called ultra high-risk population, did poorly as compared to those with 1 high-risk abnormality or none at all. And perhaps the reason for that is they stopped the treatment early, especially at the first MRD negative results, and which, if you compare it with the other trial, the optimum trial, they continued treatment until progression, and suggesting that in a high-risk disease, perhaps we have to continue treatment on a long-term basis. So yeah, the critical points perhaps are that in high-risk patients, we must maximize the depth of response and continue to maintain the response with intensified maintenance treatment. Here in UK, we have the Myeloma 15 trial, which is ongoing, and I'm one of the principal investigators for this trial. We induce these patients with now a 4-drug regimen of cyclophosphamide, Velcade, Revlimid, and dexamethasone, and all of them receive 4 cycles of treatment followed by autologous transplant, and then there's an MRD assessment after the transplant. So those who are high risk at the beginning, there's a FISH analysis which takes place at the diagnosis. The high risk patients are then randomized to receive further consolidation cycles followed by either Revlimid maintenance or Revlimid with the isatuximab maintenance. So that's asking a question whether the combination of monoclonal antibody with Revlimid is better than Revlimid alone in a randomized way. And the standard risk patients are again divided between MRD positive and MRD negative at the end of transplant. And those who are MRD negative will only receive isatuximab maintenance, which is then again in a randomized way after 12 months. They're randomized to between stopping the isatuximab or continuing. Again, asking the question whether there's benefit of continuing maintenance treatment after patients become MRD negative, whereas the MRD positive patients are treated almost like high-risk patients, and with a different randomization set between a combination of either Revlimid alone or Revlimid in combination with isatuximab. So this trial will be asking a number of questions, and will be interesting to see after this trial finishes. Now, what's the role of upfront autograft in 2022? There are a number of trials have answered this question, particularly the IFM 2009, EMN 02, and 4 trial have clearly shown the advantage of upfront transplant in the versus late transplant. This is the IFM 2009, which compared RVD versus transplant followed by lenalidomide maintenance, and at an 8-year follow-up, the transplant arm continues to show a better PFS. However, at 8 years of follow-up, there's no evidence of any survival advantage yet, which suggests that you could make a case for if some people do want to delay the transplant, that's still an option. And the EMN trial, which consists of VCT induction followed by a randomization between transplant versus VMP intensification. And ultimately, lenalidomide maintenance also showed that the transplant arm was better in terms of PFS, although there was not definite improvement in the overall survival. And the Ford trial, which is use the carfilzomib-based induction, and they had two arms where they used carfilzomib with cyclophosphamide and carfilzomib Revlimid, followed by a single autologous transplant and consolidation, and final randomization between Revlimid and Revlimid with carfilzomib. And the other arm was basically without a transplant. And again, they showed that the transplant arm, especially the KRD autologous transplant, had a significant PFS advantage. Although again, the overall survival is, there's no still consensus on that. So therefore, autologous transplant does remain as a modality of treatment in 2022. What about maintenance treatment? Again, this has now been very well shown by the meta-analysis of 4 clinical trials, the IFM, CLGB, Jemima, as well as Myeloma 11, that the lenalidomide maintenance improves both the PFS and overall survival in the transplant-eligible patients after autologous transplant. Therefore, lenalidomide maintenance remains a standard of care. And also the tourmaline MMM3, which used ixazimab and versus placebo after the autologous stem cell transplants, also shows a PFS advantage even in the high-risk genetic group, and therefore remains another option for maintenance treatment. So to sum up, for the upfront treatment, the emphasis is on quadruple treatment. The autologous transplant remains a standard of care, and maintenance treatment continues to show benefit. What about transplant non-eligible patients? The European guidelines suggest, again, a DARA-containing regimens like DARA-RD or DARA-VMP as the first option, whereas the Americans still consider VRD or VRD light, with or without daratumumab as first option. Here in UK, we still have got daratumumab is not recommended by NICE and the non-transplant patients, and we still continue with RD or CTD and other options. But what has changed, again, there have been a number of clinical trials which have used anti-CD30 antibody in combination with the standard treatments like the MAIA and the acyclovir trial, and also tourmaline used the ixazimab in combination with Lendex. So this is the scheme of acyclovir trial, which combined daratumumab to VMP standard and showed a clear overall survival as well as a PFS advantage in favor of daratumumab containing regimen, albeit at a slight risk of infections, particularly pneumonias in the daratumumab containing regimen. Whereas the MAIA trial used the daratumumab combined with the Revlimid Dex and compared with RD, again showed benefit in the PFS. However, the survival advantage is still to be determined. This trial showed that it didn't matter whether you were frail or non-frail, you continue to show improvement in the PFS as well as the MRD negativity, even in the non-frail and frail population. There was obviously a slight risk of toxicity in the frail patients in the DRD arm. And also the tourmaline MM2, which combined ixazimab to Lendex, with again showing a PFS advantage in favor of Lendex. So that suggests that the daratumumab-based regimens are again showing a better response rate and MRD negativity, albeit at a slight risk of infection in the elderly population. Here in UK, we have the fitness trial available, where the patients are actually randomized. The elderly patients are randomized between non-frailty adjusted induction versus a frailty adjusted induction. What I mean by that is that this trial will look at objectively the importance of looking at the comorbidity index using the various frailty adjusted scores, and then it will determine as the fitness on the basis of those scores, and then accordingly reduce the doses in whether the patient is deemed fit, intermediate, or frail. And so the lenalidomide dose is reduced accordingly, and that reduces the bias of some patients if it's left to the physician that you may underdose some fit patients, or you may overdose some frail patients. So this trial will be looking at this question objectively. So looking at the relapse setting, now the options are changing because the triplets are now preferred. There are a number of triplet combinations available, which are either carfilzomib-based triplets or pomalidomide-based triplets or daratumumab-based triplets. There is obviously no head-to-head data, so we have to treat the patients on depends on their previous treatments. For multiple relapse patients, we have the availability of CAR-T, bispecific agents, and the antibody conjugates, and there are also other newer agents available. Now, how to choose therapy at first relapse? It depends on their first upfront therapy, whether they have been on maintenance, whether they had a PI-based or IMiD-based treatment, and also we have to take the patient's fitness and the preferences into consideration, and previous tolerability, the funding, and the local guidelines. So it's not very clear, or there's not one size doesn't fit all. So this is one of the patients who had been treated with a Velcade-based induction, who had a partial response and was obviously relapsed very quickly, and then was considered for a KRD-based approach because this patient was Revlimid naive. And whereas another patient who had a Revlimid-based induction followed by autograph and a long-term lenalidomide maintenance for over 6 years was at the time of relapse recently were considered for a non-Revlimid-based approach, like a bortezomib approach. So how do we decide that? And the recommendation now is that if you have a first relapse after a PI-based induction, then we must consider a backbone of triplets with a backbone of Revlimid. So you have a number of options available. There are a number of trials which have with the triplet trials like Dara Revlimid Dex, KRD in the Aspire, the elotuzumab Revlimid Dex, and Ixa Revlimid Dex. They're all showing very high response rates, and some of them, especially the Dara continuum regime, showing impressive CR rates. This is the Pollux trial, which compared Dara RD with RD, again showing a very impressive PFS and an improvement in the depth of response in the Dara continuum regimen. This is one of my other patients with who's treated with a CTD induction in Myeloma In trial followed by autograph and lenalidomide maintenance, and recently relapsed, and was considered for again a Velcade-based triplet in combination with daratumumab. Again, think that the patient may be lenalidomide insensitive now. Now, if you have a patient who has been on lenalidomide maintenance or had lenalidomide-based induction, they will be considered lenalidomide refractory. Therefore, the suggestion is that, or the recommendation is that they should be either given a Velcade-based triplet or a pomalidomide-based triplet. There are again a number of regimes available, KD and Dara-VD, pomalidomide Velcade Dex. And again, there's improved significant overall response rates with the Dara-containing regimens perhaps showing deeper responses, although it's hard to compare these regimens. So this is the Castor trial, which compared Dara-VD with VD, and again shows an improved PFS as well as the depth of response in the Dara-containing regimens. So basically, if you have at first relapse patients who are lenalidomide sensitive, then the suggestion is that we should give them a triplet of which is based on the lenalidomide and consider either you add a monoclonal antibody or a second generation PI or another monoclonal antibody. Whereas if they are lenalidomide, deemed to be lenalidomide refractory, then we should consider a PI-based regimen or backbone or pomalidomide regimen in combination with the monoclonal antibodies. However, this might change because many of these patients, if they are now treated upfront with monoclonal antibody, then the algorithm is likely to change. So what happens to patients who are double refractory, as for example, PI and amide refractory? The treatment options for them, there are the new monoclonal antibody cetuximab, which is thought to be has a better binding on the BCMA, on the CD30 antigen, is also has an independent effect of independently of the T cells. And the cetuximab has been combined with either pomalidomide dexamethasone or corpus with dexamethasone in these two trials, IKERA and IKEMA. And these were heavily pre-treated patients with 72% patients being double refractory. And again, it shows that the cetuximab-based regimens showed an improved PFS and depth of response, which was seen across all cytogenic and risk groups. So this patient was treated with the combination of isotretinoin, pomalidomide, dexamethasone, and you can see that has shown in the impressive response by this combination. We are now going to see and already seeing a number of triple refractory or penta-refractory patients. The patients who have had both IMiDs as well as monoclonal antibodies. So this is a very difficult group of patients, and they do very badly with a median survival only 6 to 8 months. So here comes the BCMA anti-BCMA agents. We know that the plasma cell express the BCMA and it's exclusively present. BCMA is exclusively present on plasma cells, not expressed on any other tissue. The BCMA is thought to promote the myeloma cell growth and the chemotherapy resistance, and the expression is associated with poor outcome and expression increase as the myeloma progresses. So there are a number of anti-BCMA agents now. The antibody drug conjugate belantamab is now FDA approved. And there are bispecific or T cell engagers, again, a number of them in clinical trials, and the CAR T cells products, out of which 2 of which are now approved by FDA. So this is the chart showing the number of CAR T cells which are in clinical trials, and again, you can see that these are heavily treated patients which are triple refractory. And you're showing an impressive response rate of 70 to 90% in this difficult group of patients. There is obviously toxicity associated with the CAR Ts, which includes nearly 70 to 80% developing the cytokine release syndrome and the neurotoxicity. However, with the experience, for the centers which are using CAR T cells, they are now experienced in managing these side effects. The 2 CAR T products, that's the ide-cel and the citrocel, have now been approved by the FDA for patients who have had 4 or more lines of therapy, including an IMiD, PI, and anti-monoclonal antibody. This is the basis on which the ide-cel was approved, and you can see that in this heavily pretreated group of patients who were penta-refractory or triple class refractory with high risk cytogenetics, there was an impressive response rate of 70%, with about a third of the patients attaining MRD negativity. And the PFS was particularly seen up to 20 months in patients who actually achieved CR. The cilta-cel is using actually 2 epitopes, 2 BCMA epitopes, and perhaps may have a better efficacy. It is shown in the CARTITUDE trial that the the response rates were about 90%, with about half of them actually receiving MRD negativity. And again, this has been approved by FDA in a few months ago. The CAR T cells are not approved in UK as yet, but it's just a matter of time. And what's now being looked at, the CAR T, given the impressive response rates, the CAR Ts are now being tested for high-risk myeloma patients as upfront. They're also being tested in randomized trials against, at the time of relapse, against the standard of care. So therefore, we're going to see a lot of it, at least in the United States and Europe in the coming years. The bispecific T-cell engagers, again, these agents target both the CD3 antigen T-cell as well as the BCMA, and they bring the T-cell closer to the myeloma cell, exactly like CAR T, except that these are available off the shelf. And there are a number of clinical trials going on with a number of agents, and some of them are targeting a different antigen on the myeloma cell. Again, the response rate, although are not as good as the CAR T, but the toxicities of both CRS and neurotoxicity is less. These agents can be given subcutaneously, which is an advantage. And if you compare them with the CAR T cells, they are obviously available off the shelf, and therefore, and because of the lesser toxicity and the subcutaneous route, these may be more suitable for as an alternative for patients who are elderly or frail. Just a word about some of the novel therapies which are available, especially the two which are approved by FDA. One is the antibody drug conjugate belantamab, or called belamaf, and the selinexor, which is an XPO1 inhibitor, which is an oral agent. The belantamab is basically a drug conjugate, which is conjugated to this agent called MMAF, which is cleared by the proteases and is released and goes to the nucleus and causes the tubular disruption, and seems to be more effective that way, or as it releases it is active agent exactly like brentuximab in Hodgkin's lymphoma. Whereas the XPO inhibitor selinexor works by inhibiting the XPO, which is normally it transports the tumor suppressor proteins out of the nucleus, and the XPO inhibitor basically tries to retain the tumor suppressor protein in the nucleus, and that's how it promotes the cell death. And the belantamab is being tested in a number of what's called DREAM trials, and the problem with this has been the ocular toxicity, which is we see in nearly all patients, and that means that these patients need a regular ophthalmological examination, and many of these patients need either a dose suspension or reduction in the dosage. And there are now a number of trials ongoing where belamaf, which on its own is not as effective, but in combination with Velcade-Dex or Revlimid-Dex, the DREAM6 and various other trials, has shown a very impressive response rates in these heavily pre-treated patients. Selinexor, as I said, is an oral agent, and is associated with quite significant GI toxicity and cytopenias. Again, but there are a number of clinical trials going on at the moment where selinexor is being combined with either Velcade, pomalidomide, or daratumumab, and the preliminary results suggest an impressive response rates in these heavily pre-treated patients. The selinexor is FDA approved for either in combination with Velcade-Dex after one line of treatment, or in combination with dexamethasone only for after 4 lines of treatment. And the word about that, the lenalidomide and perhaps the bortezomib is also going to be now off patent very soon, so that might have an impact on the availability of generic compounds now throughout the world. So to conclude my talk, both PFS and overall survival have markedly improved in recent years, and many myeloma patients now live longer. Frontline treatment of myeloma is changing from a triplet to a quadruple therapy, although it may not be available everywhere, and the guidelines may not be in conjunction with the literature. We see the deeper response with daratumumab-based treatments. However, we have to weigh this against the toxicity, especially in the elderly population. And triplet combinations are preferred at first relapse as compared to doublets. The CAR-T, the bispecific antibodies, are showing problems in triplet refractory disease. And there's now consideration for use of these agents in upfront, and there may be even trials which are considering this as an alternative to autologous transplant, or even the consolidation of the autologous transplant. And as I showed, there are a number of agents in the horizon which are showing promise in penta-refractory patients. However, obviously, the time will tell us that how we actually sequence these agents and use them in early lines of therapy. It will be interesting. And there's also the question of whether there should be an MRD-driven decisions in future. So this is my last slide, and this is what the current UK myeloma treatment pathway in 2022. The only addition is the daratumumab was approved recently in a couple of months ago as an upfront treatment of transplant-eligible patients, whereas for transplant non-eligible patients, we still are using Lendex or bortezomib-based treatments. For the second line, we are allowed to use carfilzomib-based treatment either in combination with dexamethasone or Revlimid. The third line is a bit fluid at the moment, where we can either use a lenalidomide dexamethasone with or without ixazomib. And it's the fourth line where we are allowed to use monoclonal antibodies either on its own or isatuximab in combination with pomalidomide and dex. The CAR-T is still not approved in UK, but we hope that it should be probably available or approved this year. And there are other licensed drugs which are not funded, which are available on a compassionate basis. Particularly belantamab is now can be used in triple refractory patients on compassionate basis. I think I'll stop there, and thank you very much for your attention.
Thank you so much, Dr. Farooq Wandru, for that wonderful, complete talk on myeloma, updating us with everything that has happened till today, including the UK data. We'll give you rest for 2 minutes, in which we will just sort out the answer to the quiz and declare the winners, and come back to you for the question and answer session. We have 13 colleagues who have logged in here as faculty. We have hundreds of them who have attended your talk, and I'm going to put questions in the question box. I request them to keep putting questions in the question box, and we will have time to handle all of them. So I'll just share my screen to sort out the quiz. So the quiz today was related to von Willebrand disease. We showed you a patient of type 1, and the question was related to desmopressin challenge test. The question that was asked was that if you have premature clearance of the von Willebrand factor, then what the disease is called. And the answer was that the disease is called type 1C. C is for the clearance. And this was first detected by the workers in a city of Italy called Vicenza. So it's also called von Willebrand disease Vicenza. So if you answered VWD1C or you answered VWD Vicenza, you were correct. Just to educate you on this, when you do the desmopressin test, this is the usual level of von Willebrand factor RECOF, the platelet binding activity, where even after 8 to 12 hours, the levels are pretty high. But if you have type 1C, then when you do the 4-hour level, usually you do 1 hour and the 4-hour levels would be very much down. And this is the patient who cannot be managed by desmopressin even for a short surgical procedure. So enhanced von Willebrand factor clearance in patients of von Willebrand type 1C. This is von Willebrand factor antigen, once again showing you the same stuff in type 1C, the levels drop off. So typical desmopressin response in patients of type 1C, where 1205 is substituted. At the site 1205, there is a substitution, demonstrating an initial significant rise, as you see over here, followed by a very rapid drop due to the accelerated clearance. So these patients can also be identified using an ELISA-based test in which you measure VWF propeptide. However, that particular test is not widely available. So in practice, you use the truncated VWF response following desmopressin. This is a British Journal of Hematology article published 4 years ago, talking about the biological mechanism of this rapid clearance. And there's some role of macrophages in this clearance. Now, this is one cartoon showing you increased clearance, von Willebrand factor, and the role of macrophages. This accounts for not a small number, 40% of patients of von Willebrand disease type 1. It's very important because these patients cannot be managed by desmopressin. So the answer was type 1C or type Vicenza, or whatever, both you answer. We had 15 correct answers. 14 of them are listed here from 2nd to the 15th in the order in which you got the correct answers. I will tell you the winner later on, but the second fastest was Dr. Reema Miria Ibrahim. And then you have Ramesh B, Yoga Lakshmi, Gopinathan, Ashwarya Raj, Naved Tamboli, Alpesh Kapadia, Akanksha Garg, Satitha Satyanthan, Vinod Sharma, Thomas Puncheria, Virti Shah, Sumit Mirk, and Yatendra Parashar. You answered at 11:42 a.m. to 12:15 a.m. So that was the time duration during which we got these 14 correct answers. And the winner, the fastest finger fast, is Dr. Asif Iqbal at 11:41 a.m. You know him very well. He is there today as our discussant as well. He is assistant professor, DMG, adult hematolymphoid, Department of Medical Oncology, Dr. Bhubaneswar Barua Cancer Institute, Guwahati, Assam. So congratulations, Asif, to you, and we will send you your prize amount into your account very soon. I'll stop here. We'll go to the question and answer session. I can see the raise hand signs. We will go accordingly. Plus, intermittently, we'll take up questions from the audience as well. Starting with Dr. Jay Chandran. Unmute yourself, Jay Chandran.
Good afternoon to everyone. That was an excellent talk, Doctor. So I would like to ask a technical question pertaining to India. So we do not have any fancy newer drugs in India, like the CAR-Ts and other drugs. Even daratumumab is not affordable for everyone. So I have a patient who is 38 years old, who is a plasma cell leukemia. So do you consider, in that case, would you consider an allogenic stem cell transplantation as a second after autologous consolidation? Where would you place a role of allogenic stem cell transplantation pertaining to India in 2022?
Thank you. Yeah, I think, plasma cell leukemia obviously is a very, very high risk spectrum of the myeloma patients. And there is no, obviously there's no randomized data to recommend anything. There's no consensus, but these are obviously high risk, and basically we have to use a very intense induction and a consolidation treatment, whether that consists of DT-based induction, followed by one of the options would be an allogeneic transplant. Yes, but in fact, that's one of the indications for allogeneic transplant, if at all, is in myeloma. But you obviously have to look at the transplant-related mortality, which is quite high in myeloma with the allogeneic transplant. I mean, we don't routinely do allogeneic transplant in myelomas, but that I would say that's probably one. And what people probably recommend, those who are transplant experts, they probably would consider an autograft followed by a REC-allo, a reduced intensity allograft. And I think then that will probably be followed by some kind of a maintenance, especially in a now whether the daratumumab induction-based treatments will make a difference. It's very difficult to know. As I have shown you 2 trials where they're combining daratumumab with carfilzomib-based intense induction followed by consolidation and maintenance. Whether that will make a difference in the outcome is difficult to know. But at the moment, I think if you look at the expert guidance from Mayo and other places, they would say a very intense induction and with or without a transplantation.
Thank you. Thank you, Doctor.
Thank you, Dr. Jayachandran, for that question, and thanks, Dr. Mangrove.
I don't know what others, the transplanters might, and the panel might have a question. I have an answer to that.
If there is a comment from anybody on this question, we'll move on to one question from the audience. Dr. Ramesh wants to know, in the Radar trial, you mentioned isatuximab to be given in maintenance. Why not daratumumab? Any specific reason?
I think that's the question, really. I mean, it has not been tested at all. I think the reason might be because isatuximab has got a better binding and, perhaps a better in vitro efficacy. And also, I think it might be that, when these trials are set up, there's a collaboration with the companies, and the companies might have, they fund these treatments. So that's one of the reasons. But neither daratumumab nor isatuximab, we don't know the role of maintenance treatment at this stage. So this is a trial.
Thank you. Dr. Parathan?
Yeah, good afternoon, sir. So my question is regarding the sequencing where to place daratumumab. So you had mentioned the NICE guidelines that for transplant eligible, DARA is approved for upfront treatment, whereas for transplant ineligible, it is approved at first relapse. So for a country like India, where we have slightly more limited options, where would you recommend that we place daratumumab at upfront setting or at first relapse, which would have the maximum benefit?
I think if we look at the data for the VRD or VTD induction treatment, I mean, that's not bad. I mean, the aim of treatment should be basically to get patients to the very good partial response. That's what the aim is. Irrespective of what induction treatments you use, and with a view that if you have a younger patient, that he goes for an autologous transplant. Therefore, I don't think, if because of the cost issues and because of the non-availability of the drug, I don't think daratumumab is necessarily to be used at this stage as an upfront. And for the elderly, again, there was evidence of increased infections in the daratumumab-containing regimens. Therefore, I think RD or RD light type of regimens are still, you could call a standard of care in elderly patients. So yeah, so it's not necessarily to use daratumumab as upfront at this stage if for those reasons.
Thank you. One more question from the audience. Dr. Roshni Pandey wants to know, can you defer the upfront autologous transplant to a little later stage, especially if you're doing MRD monitoring? Does it make a difference to the progression-free survival?
No, I think this has been looked at a number of trials, and I showed you a few, that there's not been actually demonstrated overall survival advantage with autologous transplant. We have only the PFS advantage with most of the trials. Particularly if you look at the IFM 209 trial, which compared VRD with the transplant, there was an update at the ASH at 8 years, follow-up, there's not much difference in the overall survival. So therefore, a case could be made of that, if for whatever reasons that patient is not opting for a transplant, you could continue with the treatment. The reason for the difference in the outcomes in different trials, because it depends on what the types of inductions used, and that may make the difference. But at the moment, I think if you look at the BSH guidelines, they also say the same, that you could although the transplant is a standard of care, but it doesn't have an impact on the overall survival, and that's why also they are now thinking of the CAR T cells. CAR T therapy might actually come upfront somewhere in there, that why the autologous transplant is an option. But yes, you can delay. It doesn't make a difference to the outcome if they have a late transplant.
Thanks. Dr. Bharat Parikh.
Dr. Farooq, I have a question for you. Your views on venetoclax in penta-refractory myeloma, where particularly T1114, where other treatment options like CAR T or bispecifics are not available in this part of the world. So about venetoclax.
Yeah, I think I just didn't. Thanks for this question. So I didn't include the Ven data on the because the time concentrates. Yes, I mean venetoclax obviously has been tested as a single agent as well as in combination with Velcade-Dex in Bellini trial, and it did show a response in the and improved the PFS, but there was no survival advantage. In fact, the Ven norm actually had increased deaths for whatever reasons. So therefore, FDA actually withdrew this agent, although it has now been again being considered. But there's a suggestion that the patients who have a high BCL2 expression, irrespective of the 1114, it might have a role in that. So I think in 1114, yes, it has a role in combination with the Velcade-Dex, and maybe in the high BCL2 expression also. But I think time will tell. But I'm not sure. You have got venetoclax available in India, isn't it?
Yeah, that's why this.
Yeah.
Thank you, Bharat, for that question. Dr. Shahid, your question. Unmute yourself. Unmute, Shahid.
Yes, am I audible now?
Yes.
Yeah. Good morning, sir. Thank you so much for that wonderful talk. My question may not be directly related to myeloma, but it is a subgroup, and I think it is an important part also. The antibiotic prophylaxis. Like we have been using Bactrim DS for a long time as an antibiotic prophylaxis, but for I think last 1 or 2 years, it is levofloxacin which has come up. Since you have seen both the side of the world, in India also and in UK also, what do you think for Indian population, whether Leoflox or Septran, because in India we also have a lot of antibiotic resistance, and TB is also quite common in India. So your take on this?
Thank you for asking that question. I mean, again, I didn't show that slide. I should have shown that. If we look at the cause of death in myeloma in the first 3 months, the cause of death in myeloma in the first 3 months is not myeloma, but it is the infections, it's the pneumonias. About 10% of deaths are because of pneumonias in the first 3 months, especially during the induction treatment. So we were part of this large trial called TEAM trial, which I was one of the principal investigators, and that was actually originated from Midlands here where I work. And that's the first time actually that question has been asked, that if you use ofloxacin prophylaxis along with Septran, it actually did show that the incidence of infections were reduced, as well as there was a mortality benefit. So that trial, as now you must have seen, is published I think last year, and that has actually changed the you can call it standard of care now. It's now recommended by all the professional bodies that we should recommend ofloxacin as well as septrin prophylaxis. And because we use very heavy dose of dexamethasone, that puts these patients at a very high risk of PCP. So what we do now, we use ofloxacin as well as septrin as prophylaxis during at least first 3 months of induction treatment. So that's probably what should be. I mean, that's the only evidence we have.
So how long do you continue, sir? Like you stop it after 6 or 7 months?
Yeah, we stopped after induction treatment. Yes.
Thank you.
Yeah.
Thank you, Shahid. Dr. Abha.
Thank you, sir. So my question is, as you mentioned that the definition of plasma cell leukemia has shifted from more than 20% cells to more than 5% cells in the peripheral smear. Why leave those, between 1 to 5% cells behind? I mean, if we have like less than 5% cells in the peripheral smear, the plasma cell, would you treat it like plasma cell leukemia or like a high-risk myeloma?
Yeah, I think, well, obviously definitions are definitions. They obviously the analysis must have been done at all percentage of cells, and they found that 5% was same as 20%, so treated as plasma cell leukemia. But yes, there is evidence that patients who have got high circulating plasma cells, they are very actually high risk, and this is what has also been seen in the isotope study which I showed. While they screened the patients for MGUS and smoldering myeloma, they actually looked at circulating plasma cells. And those patients actually have a high risk of progression to frank myeloma. So I would say that, yeah, they are also high risk. The circulating plasma cells is a bad sign. I'm sure if you do genetics. Yeah, I mean, I think if you had access to fish testing, and then you would be able to find out the genetic changes, that will basically solve the question. But without that, it's difficult to say that you would treat them as high risk. But yes, my guess is that these will be high risk patients.
Thank you.
Thank you, Dr. Abha. Dr. Farooq, you have discussed venetoclax, but I think Professor Raja Bandopadhyay has joined in late. Can you just comment again on the use of venetoclax and its rationale?
Yeah, the venetoclax was, as we looked at in the Bellini trial, where they compared, combined venetoclax with Velcade dexamethasone, and it did show improved response rate and PFS benefit, but it didn't show the survival benefit. In fact, there was, in the venetoclax arm, there was increased deaths contrary to what was expected, which wasn't very clear as to why. So it was temporarily withdrawn by FDA, and then it has been again not approved, but it is still being allowed to be considered the clinical trials. So there does seem to be a response in the patients 11-14 translocation, and also there's a suggestion at the subgroup from that subgroup analysis that patients who had a higher BCL2 expression, it actually may have an advantage and may improve both PFS and overall survival.
Thank you. Sorry for that repeat question and the repeat answer. Thanks for satisfying him. Coming to Dr. Asif, first of all, congratulations for winning the quiz today. You were very, very speedy.
Thank you, sir.
Others were almost 1.5 minutes after you. So congratulations. Dr. Asif Iqbal is our young hematologist, torchbearer of this branch of medicine in Assam, Guwahati. He's been very, very active with our activities. So your question to Dr. Farooq.
Sir, I wanted to ask you, we have seen an overwhelming data regarding MRD negativity as far as the progression-free survival is concerned. Because what routinely we are doing is light chain assays as response assessments. So for deeper responses, we are looking at the free light chain assays. And both are costly. Doing a MRD by flow cytometry and doing a free light chain assay also costs 8,000 rupees in India. So if we are doing MRD for response assessment in those patients who are in CR, can we do away with the FLC ratio? I mean, does that make sense that MRD negative patients will always be SCR? Is it so?
Yeah, I think the question you have to first ask yourself is, why are we doing? What are you basing your treatment on MRD? So how does it make a difference whether you test them or for MRD or not? I mean, are you actually changing the treatment on the basis of MRD?
No, we are not changing that. no, we are not changing the treatment. So what I'm looking at it is the level of response. So if MRD is being tested, can we do away with the FLC testing? I mean, does that make sense? Because we are not routinely doing MRD by flow. That's the kind of thing that is it important to incorporate MRD by flow cytometry in our routine practice? And does that alleviate the use of free light chain testing?
I think it depends upon, I mean, there are obviously different types of MRD assays people use. They're mostly in the clinical trials, they use the flow, or they use the next generation sequencing. I'm on the question of MRD is, whatever method you use, is that we have to ask a question to ourselves: is what are we trying to get from it, and how is it actually useful to for the patient in terms of, does it help us to make a treatment decision? I mean, in the routine clinical practice, I don't think it helps us to make a treatment decision, because you're not going to decide on maintenance whether you would want to give maintenance to somebody or not, because that's still a trial question.
Yes, sir. We are doing maintenance anyways.
Yeah. So unless you want to decide after 12 months of maintenance to, like the trial I showed we do in UK now, that whether you want to stop somebody's treatment and you want to do an MRD, then that makes sense. But again, that's not it's still a trial question. We don't know whether maintenance treatment long-term benefits all, or whether there will be a subgroup of patients where you could stop it. We don't know that as yet. So, I don't think we should necessarily do MRD at all, except do the routine immunoglobulin assays and demonstrate VGPR by that.
Right.
Thank you, Asif. Another question from audience. Dr. Upendra Sharma from Jaipur wants to know about 1Q gain and 1Q amplification, and how do you make use of it in risk stratification of myeloma?
Yeah, I mean, I think that's what has been shown, that both the number of cytogenetic abnormalities and the type of abnormalities, like particularly they looked at the amplification of 1Q is worse than just gain of 1Q. That's what was shown in the myeloma 11, and that puts them at a more high risk, or you can call it ultra high risk. But what do we do with that? At the moment, we don't know. There are now, the trials which I showed there, looking at whether the ultra high risk patients with either multiple abnormalities or there's different abnormalities, whether they should be like biallelic or mutation, whether they should be actually treated differently. We don't know as yet. We don't know how to even treat the high risk patients. So it's just becoming apparent that there's a subgroup of these high risk patients who are doing badly.
Thank you. Aishwarya, your question.
Thank you. Good morning, sir. Thank you for the wonderful update. So my question pertains to second transplant. Suppose in the Indian context, we have a young fit person in the 5th decade who relapses following an auto transplant around between 7 to 10 years. So once we again get him in remission, would you go for what benefit does an allo transplant have over an auto one in the repeat second transplant?
No, I think the recommendation is that if you have somebody who had a PFS beyond 2 years after first autologous transplant, or if they have been on maintenance, because now many of the patients may have been maintenance, which is more than 4 years after maintenance, and then they relapse, then if they have a second induction and you achieve again a VGPR, and they are fit enough, and you have had adequate stem cells already collected, then the recommendation is that we should go for a second autologous transplant in that setting. Whereas if you have less than 2 years of PFS following the first one, or within 4 years of a maintenance, then the recommendation is not to go for the second autologous transplant. In terms of allogeneic transplant, I think that's debatable. Given the high TRM with the allogeneic transplant in myeloma setting, although there is a graft versus myeloma effect, that's a debatable. Maybe for a very high risk patient, that can be considered, as I said earlier on, but otherwise, allogeneic transplant is not, given that, we've got so many treatments available nowadays, that is kind of a questionable thing.
Thank you, sir.
Thank you, Aishwarya. Ankit?
Yeah, thank you, sir. Dr. Vandru, I want your opinion regarding the patients who are fitting into smoldering myeloma. This is after revision of 2016 definition. So they don't have CREB criteria, they don't have SLIM criteria. So how often would you monitor them, and is there any indication to start them on treatment? And if so, what treatment would you refer them to? And second part of question is same for a patient with MGUS with CIDP or MGUS with renal significance patients.
Yeah, I think as far as the monitoring is concerned, if you have, obviously smoldering myeloma with SLIM criteria would be myeloma. We know that's what we know that. So they have to be treated myeloma. But anybody who has got a plasma cell load of below 60% or below 50% particularly, and say between 10 and 50% or 10 and 40%, and without any prior criteria. So they are smoldering myeloma by definition, and therefore there's no standard recommendation for treating them as outside the clinical trials. There are these subgroup of patients which I showed. In them also, depending on their free light chain ratio, the plasma cell index, and genetics, etc., which might tell you that which group them might progress early. But there's no standard of care in terms of treating these patients. So we monitor them more frequently. So you monitor them 3 monthly with the repeat immunoglobulin serum free light chains. Whereas the MGUS is low risk MGUS is as defined by the IMWG, those who have got a small paraprotein with no immunoparesis and everything else normal. We just actually discharge them from the hematology and to the primary care to monitor them 6 monthly to yearly, basically. And there are so many of these if you come to the UK practice, because of the elderly population we see, this is being picked up now everywhere. And as I showed from the isotope study, you can see that they are all around there. And we know that only 10% of these will ever develop myeloma. If somebody is in his 70s or 80s, his chance of developing myeloma are negligible. So we actually discharge them. But the high risk ones, where there's a slightly higher M protein with immunoparesis, or like, for example, IgA MGUS, we might see them for first few years, at least 6 monthly to monitor them. And if by 2 to 3 years, if they don't show any progress, then we again discharge them. That's, if you look at the graph from Vincent Rajkumar, which he shows all the time, there is a subgroup of these patients who might progress in the first 4 to 5 years. If they don't, then they don't. The curve then flattens after that. So that's how we do these patients.
Right. And one more question, if you allow me. I've noticed in NICE guideline, the patients who are not transplant eligible, they receive melphalan in combination with Velcade or some other drug. There is no Revlimid, there is no daratumumab in first-line therapy. Is there any rationale behind avoiding this more effective agents in first-line therapy in patients who are not transplant eligible? Or is it just triage?
No, in the NICE guidance for transplant non-eligible patients is basically either, it says CTD, cyclothaldex, so that's what the UK trials used in the myeloma 11 trial. Whereas in the Europe, they used MPT, melphalan thalidomide, which is kind of similar or may actually have shown slightly better results than CTD. So the NICE guidance currently it says CTD, but those who are thal intolerant can be given Revlimid. So we actually use RD on the basis of the first trial, the RD actually is the standard of care at the moment. If you've got obviously other options also, you can use VMP, we can use MPT, we can use Velcade Dex. There are many options there, but the DARA has not been approved in UK for elderly patients.
Okay, right. Thank you.
Thank you, Ankit. Dr. Parathan.
Yeah. So my question was regarding myeloma patients who present with acute kidney injury. High creatinine and light chain loads of 3,000, 5,000 like that. So what is it that you routinely practice in status? Do you advise plasmapheresis or high cutoff dialysis, or you just treat the myeloma and wait for the kidney injury to solve?
No, I think we give them a good dose of dexamethasone to start with, because that's quite protective. Fluid management, and then we use a proteasome-based induction. Just either we basically use obviously Velcade-based induction, but people can use corpuscle-based induction, the majority of these patients would respond to that. We don't routinely recommend plasmapheresis. In fact, there was a large trial run by Birmingham University many years ago. They used a large, what do you call as a Gambu filter or something to filter these plasma proteins, and they did a randomized trial. It actually did not, I think that's published, that it didn't actually show benefit against chemotherapy only. So I think the current recommendation is that you use a Velcade or PI-based induction treatment for renal failure. And again, renal failure is not a contraindication for autologous transplant. You can still go for autologous transplant with reduced melphalan conditioning.
Thank you. Dr. Ankit Jitani.
Good afternoon, sir. So, sir, in patients who have relapsed after autologous transplant and are refractory to multiple lines of available therapy, including the PIs, IMiDs, and daratumumab in our setting, do you still fall back to melphalan? And if yes, in what combination do you use it? What doses, and how do you optimize therapy in such patients?
Yeah, I mean, I think that's a great question, and yes, you will obviously see more of these patients now because we're using a lot of IMiDs and PIs as upfront, and you might even use daratumumab now at some point. There has been this, if you look at the algorithms from various professional bodies, including look at Mayo and others, they do say that alkylators do retains activity against myeloma, and so at the time of relapse, when we haven't got other options, it is a good consideration that you can use any alkylator for that matter, whether you use a cyclophosphamide-based agents or melphalan-based agents. With steroids, I don't think there is a particular dosage as you would use in the upfront. You probably use the same way. There are some experts who would also say you can use actually intravenous melphalan, like you would normally use for high-dose therapy, and maybe a 1/3 dose of that you could actually consider. And so alkylators, yes, they're saying myeloma still retains the activity against alkylators, because when these patients who have become refractory to other agents relapse, you don't know which clone is actually grown, because it's one of the clones has taken an advantage, and that might be still alkylator sensitive. So that is a definite consideration in these situations.
Thank you, Dr. Jitani. Dr. Shahid again. Yeah.
Yes, sir. Thank you. Sir, in India, now whether a patient is a transplant eligible or ineligible, if the patient is reasonably fit, VRD is the treatment of choice that we all use VRD now. Suppose a patient who relapse in 5 to 6 months, like how do you optimize the next line of therapy? Like how do I get to know whether it is a PI refractory or IMiD refractory? Those who have got both the drugs in the first line?
Yeah, I mean, I think patients who actually relapse within 6 months, you said, is that right?
Yeah, he said.
Yes, sir. Yes, sir.
Yeah, I mean, I think that's a very poor prognosis. So patients who relapse within 18 months, especially if they also had a transplant, they are also deemed as high risk patients. So, you know, those patients should be, if they are young enough, fit enough, they should be actually induced with a very heavy regimen, for example, like the DT pace or a VDT pace they use nowadays, to induce them again and, you know, consider some kind of a high dose procedure in autologous transplant. Whereas patients who relapse, you know, later on, several years after, then I think you use the same algorithm as I showed, you know, whether they are, depends on what they had initially. If they had an IMiD-based treatment, then you use a triplet therapy, which is proteasome-based. If they had proteasome as baseline, and then you can use Revlimid-based triplets. If they are Revlimid insensitive, then you use either a pomalidomide or a PI base. So that depends on it. But if they are relapsing within 6 months, that's a very bad sign.
Okay, sir. And sir, if you allow me one more question.
Yeah, go ahead.
As a, suppose a patient who has a high bulk of disease, like lot of extramedullary disease also, like we know they are high risk patients. In such patients, like what is your choice of treatment? Do you start with usual triple drug VRD or something, like you prefer first a chemo-based regime to reduce the bulk of disease, and then we can plan for this triple drug or immunoproteasome?
Again, there's no randomized data, and I think again these are very high risk patients. Extramedullary disease is another you know, poor risk condition, and there isn't any clear recommendation. But again, people would say, you know, use very intense regimens like DT pace again to control the disease, because whatever you use otherwise, it is going to be short-lived. So if we can achieve some kind of a remission with a whichever combination regime you use, and they should have to be followed by a high dose procedure there. But it is a difficult, you know, it's a high risk area, and you know, it depends upon the patient's performance status, whether they could tolerate a DT pace type of a regimen. All of this might work, but they will work temporarily.
Thank you. Dr. Bharat.
Thank you, sir. Dr. Farooq, you have mentioned in the upfront induction therapy for the newly diagnosed multiple myeloma who are transplant ineligible. One of the regime was RVD light. What are your views on RVD light? As in many of our patients who are elderly, who are frail, and we are afraid of the toxicities, their acceptance and tolerance will be much better with RVD light.
Yes, I mean, RVD light was a phase 2 trial, which a US trial, and they used obviously smaller dose of Revlimid, about 15 milligrams, as against the 25 milligrams, and that actually did show a reasonable response and progression-free survival in the elderly group of patients, and that is what is being used by the US. You know, they do consider RVD light in the elderly population as against VRD. And that's a reasonable treatment option for non-transplant patients. In fact, if you look at the fitness trial, which I showed, which we're running here in UK for the elderly patients, that's now actually using the same approach, that you're using Ixo-Lendex, but the lenalidomide dose is being reduced to 15 and 10 milligrams, depending on the frailty. And they're actually formally now assessing it. But, you know, RVD light exactly showed the same thing, that, you know, and in our clinical practice also, we see that the elderly frail patients will tolerate a lower dose of lenalidomide and lower dose of dexamethasone. So that's a reasonable thing to do.
Thank you, sir.
Thank you. Dr. Ankit Rayani, and then Dr. Shahid. Ankit.
Thank you, sir. So my question is regarding a specific case scenario. 55-year female, initially diagnosed as end-stage renal disease on dialysis, and meanwhile, as a cause of renal failure, she was worked up and was found to have multiple myeloma. So after that, she had presented to us, and she was brought into remission with Cyborg-D. And meanwhile, the patient did not, the renal function did not recover, and the patient is still continuing on hemodialysis. And then the question is that she was waiting for renal transplant, and meanwhile, she had a relapse of disease, myeloma. And again, we had brought her into remission with cyclophosphamide, pomalidomide, dexamethasone. So question is, what comes next? With the renal transplant first, or should we proceed with autologous transplant while she's on hemodialysis? And if so, what would be the dose modification?
It's a difficult one. I think it's a kind of a, as the amyloid being ruled out, yeah.
Yeah, it's ruled out. Yeah. It's kappa type, and there is no amyloid.
Yeah, I mean, I think this is something which has been taken as a multidisciplinary discussion with the nephrologists, and you know, what's her urgency for renal transplant. Obviously, she is dialysis dependent, and they would say that that probably takes the priority. But will they do a transplant if somebody has got a florid disease? That's another question.
Yeah, but then she has now brought into remission, so they want a clearance from us. And my question is whether we should do autologous to consolidate, or whether we can go ahead with renal transplant.
You know, it seems to me that probably renal transplant would be the first thing to do, and then you could probably, rather than doing an autologous transplant, you might consider giving some kind of a maintenance treatment to maintain the remission, rather than going for an autologous transplant, because you're not going to cure her with the autologous transplant. You're just going to prolong the remission. But you know, autologous transplant might be risky. So she might get away with some kind of a maintenance treatment to maintain, or maybe a bit of a consolidation after the renal transplant, and then maintain with some you know, Revlimid maintenance might be a better approach.
Okay, thank you.
Thank you, Ankit. Shahid, you have a question?
Yes, sir. Yeah. So like in India, like there are so many patients who are eligible for transplant, they deserve transplant, but due to many reasons, maybe financial or some other reasons also, many times they do not prefer transplant. So what is your strategy, like in such patients, what should be the strategy of maintenance treatment, like the duration of how long should I give the maintenance, and what should be the strategy of maintenance in such patients? A practical question that we usually face a lot of such patients.
I mean, these are otherwise transplant eligible.
Otherwise transplant eligible patients.
Yeah, I mean, if you look at the UK practice, we are not allowed to use landed maintenance if patients didn't have transplant. So very strange, because the evidence is for post-transplant landed maintenance. If you look at the Myeloma 11 trial, they use land maintenance after stem cell transplant. So if a patient in my practice was transplant eligible but did not go for a transplant for whatever reasons, we will not be allowed to use land maintenance. It's not funded as for the trial. But you know, to be being pragmatic, I would say, you know, land maintenance should work, and if they have achieved a very good VGPR, and so we should use the standard dose of lenalidomide and use it continuously. I wouldn't stop till they progress, basically. Like we use in the elderly patients who are transplant ineligible. We continue RD. Continuous is better than RD with interruption.
Thank you.
Thank you, Shahid. Dr. Afaq.
Thank you, sir. Thank you, Farooq, sir, for a wonderful lecture, a wonderful talk on what has changed in myeloma in 2022.
I thought people in Srinagar were still sleeping. I didn't hear anything.
Yeah. It's too cold out here.
Right.
Yeah. So a lot of things have come up in myeloma. Many things, many agents have been incorporated into myeloma treatment armamentarium. But the fact remains that myeloma is still an incurable disease, and there is still an unmet need for high-risk myeloma. And what I believe is that first 6 to 12 months are crucial for myeloma. it is a dictum that if you want to treat myeloma, it is better to hit hard early than to be late, because if you delay their don't give the optimal treatment upfront, then managing the relapse will be more difficult, more and more difficult. They will be more and more unresponsive. So the query is that have we optimized the best upfront regimen as yet? You touched about daratumumab, you talked about bringing CAR T-cell therapy upfront. So that is my question, that have we sort of optimized the best treatment upfront, and then the sequencing in the relapse setting. So what are your thoughts on that?
Yeah, thanks for your comment. Actually, yeah, I didn't show that the slide which every myeloma specialist shows, that, you know, looking at the trajectory of myeloma patients. So you give first treatment, then second treatment, third treatment, and after every treatment, the remission is shorter and shorter until they become refractory. Now, and therefore, and also there is now evidence that only about 30% of the patients actually get to the third or fourth line. You know, majority of them will scump before that. So therefore, it's important that the first line treatment is the best line treatment, as you said, so that you can achieve some kind of a remission, and you can maintain it with consolidation and maintenance treatment, so as long as you can. Therefore, the best treatment, as I agree with the upfront treatment. I mean, obviously, we have learned from the clinical trials over the years, over the decades, that, you know, gradually combining these agents, you know, we've now come to a stage where we're using multi-agent upfront treatment, and now we are using quadruple treatments, which is giving you a better depth of response and a PFS, and is expected that because we are seeing more MRD negativity, that it will also translate into overall survival. And then we maintain it with the maintenance treatment now, in other words, continuous treatment till they progress. So yeah, I think that's what's the expert consensus, that you use a quadruple regime upfront in standard risk we're talking about, followed by continuous treatment till they actually progress. That's what the evidence also is. And as far as high risk disease is concerned, and its jury is out, but as I said, the recommendation is that we must use very intense induction and consolidation, and try to use a continuous treatment. If you stop treatment, these people relapse very quickly. That we should use the continued treatment after the consolidation cycles, and if we can.
Thank you. Thank you.
Thank you, Dr. Afat. Couple of questions from the audience. Dr. Babita Sodi wants to know, what is the youngest age at which you have seen myeloma and it has been reported?
Good. So good question. And the question should be asked to me, actually. So I had the youngest myeloma patients in Midlands. And I thought I had actually the youngest myeloma patient in the UK, but I was actually challenged recently. So my patient was 28. She was a young girl. And I thought that was the youngest. And she actually, did well with the treatment, and then became pregnant actually last, I think she just delivered 6 months ago, a baby, which is again a kind of you could call it a case report, because not many myeloma patients have delivered babies. So that is one of the 35th or 36th cases in the world literature, I think. So that I thought was the youngest, and she's doing very well at the moment. But then I was challenged that there was an 18-year-old boy diagnosed with myeloma in the UK, in probably Marsden or somewhere. So the place where I work in Birmingham is West Birmingham the population is of a lot of Afro-Caribbean people and Asian people in the West Birmingham side, and we know that myeloma is quite common in Afro-Caribbean. People with Afro-Caribbean ancestry, MGUS is quite common there. Therefore, we see a lot of younger patients. So I've got lots of patients in their 30s, actually, lots of patients in 30s and 40s. So, and if you actually look at the first case of myeloma, which is reported in the literature, if you Google it, that patient's only 38. That is surprising. So yeah, there's a spectrum, yeah.
Second part of the question is, do you handle them differently?
I mean, handle them differently would be, and yes, younger patients, you know, I don't think we handle them differently, because question would be asked whether you would go for an allogeneic stem cell transplant. In my last 20 years, we've only sent one patient for allogeneic stem cell transplant, and she has actually done well, contrary to what we see. But we didn't, I don't think allogeneic stem cell transplant is a kind of a routine for younger patients, unless they have got a very aggressive high-risk disease. So we don't necessarily handle them differently, no. We treat them like a transplant-eligible patients, and yeah.
Okay, then one last question from the audience is, multiple myeloma, renal dysfunction, develops DVT. What is the anticoagulant of choice?
Multiple myeloma with renal failure, is that right?
That's right.
Yeah, I think you would treat them with as you would treat anybody else, except in renal failure, obviously, if you were to use DOACs, you can't use them when the eGFR is below 15. So if your eGFR is above 15, then you can use a DOAC. And also you can use, obviously, warfarin would be the drug of choice if you look at it, because warfarin is not metabolized through kidney. So warfarin would be a best treatment. With the heparin and DOACs, you'll have to look at the actual eGFR. As long as it's above 15 or 30, then you're safe. I mean, that might lead us to one more question, which we didn't talk about, is the using thromboprophylaxis in patients with myeloma, who are on IMiDs and steroids. And again, there's variable practice. We have been using heparin in the past, but we have recently changed our practice to, DOACs like apixaban and like that in the patients who are on IMiDs. So that, and some people, especially in US, use aspirin. So I mean, anything is actually allowed. I don't think there's any randomized data as yet.
If there's any question from the faculty here, otherwise we're going to close this session. Nothing. So, okay. Dr. Farooq, thank you very much. 2.5 hours you have been with us. You patiently answered everything that was put to you. We have had myeloma sessions in past, but you can realize how much enthusiasm and how many unanswered queries were there from senior colleagues over here and the audience. The subject has been evolving rapidly, and it does require update, and you have done a great job for us. Educated people, not only from India, I think, again, the figure is almost 24 countries. Delegates have logged in, and each person who got educated will in turn educate many more, and the patient care will be superior. Thank you so much. Getting up early morning on Sunday, being with us. Probably your delayed breakfast is waiting for you, and family is waiting for you. Thank you so much for being with us. And on behalf of everybody, I'm grateful to you and the colleagues. All of you have spared your Sunday for this academic session, and the delegates and our sponsors and the event manager team. Thank you.
Thank you very much. It has been a great pleasure to interact with you. Thank you very much.
Bye to everybody.
Goodbye.
Thank you.